we'll start with introductions. So this is the session on parental authority and decision-making in pediatric ethics. Again, we appreciate you all being here. And you all got a preview of our case. They talked about it last session. So we will be talking about a case of questions around testing for death by neurologic criteria in a minor child. We'll start with some introductions though. So I am Sarah Porter. I use she and her pronouns. I am a social worker by training and a current social work manager at Legacy Health. I also am a pediatric clinical ethics consultant, and I work with Drew to do the neonatal, pediatric, adolescent, and maternal fetal ethics consults at Randall Children's Hospital and for the Legacy system as a whole. And Drew, I'll just say for both of us, we're thrilled to be here and appreciate you all being in session with us. So I'll let Drew introduce himself.
Yeah, no, when appreciations always come better from Sarah than myself, but I also appreciate y'all being here. I'm a pediatric rheumatologist in my training and have done pediatric ethics for quite some time, and am really lucky to be able to help Sarah and myself do pediatric consults for Legacy Health. And we're excited to talk to you guys today.
Oh, that works. So first off, we have no disclosures to report. I actually forgot to put this slide in here because I can't imagine ever having a disclosure, but we don't have one. So I thought I'd plop that on in there.
All right, our objectives. So we hope by the end of this, you guys are going to be able to understand the difference between parental authority in pediatrics and the difference between that and autonomy in adults. Also, to describe the the role of certainty and uncertainty as it relates to the ethical concepts of harm, best interests, and parental authority. And then finally, to describe how to consider parental authority in ethical decision making in the pediatric case that we're going to throw out for you, and probably a couple of others as well.
Yeah, so this, Drew, I'll let you read our case. I gotta figure out how to click. There we go. But I will just say that Drew and I made a conscious decision to pick a case around death by neurologic criteria, which is a hot topic for pediatrics. It's largely discussed and debated across the country for our colleagues. And we're going to take kind of a different look at it when we look specifically at the testing question. But our goals are to give you some information around parental authority, define it for you, kind of compare it to competence as it shows up in the adult populations, and then see how we can apply it to what can certainly be the controversial topic of testing and determination of death by neurologic criteria.
So our case, Rose is a 7-year-old who's a previously healthy child who presented after falling out of a slow-moving farm tractor. She suffered a devastating head injury with a need for a decompressive craniotomy. There was immediate concern for the survivability of her injury. She was provided full and extensive medical care with active efforts to decrease cerebral swelling. 3 days into the hospital stay, Rose had not improved. She had no purposeful movements and has all the bedside clinical signs of death by neurologic criteria. The Peds ICU team believes it is time to move forward with brain death testing, but the mother was firmly against testing and is hoping for a miracle. Rose's parents are separated. She splits her time between their homes with her 5-year-old sibling. Father is not against moving forward with testing, believing his daughter is quote unquote gone. Mother is supported by her family and the faith community, and despite extensive meetings and information sharing, remains adamantly against brain death testing. So parental authority versus patient autonomy. And again, when we talk about autonomy in ethics, we're typically looking at that with respects to individual adult patients with the capacity of getting to make their own decisions. The person gets to identify what is in their own best interest and really only needs to consider themselves. They may have other outside influences that change those decisions, but again, they're really focused just on what um, who they are, what has meaning to them, and what they're looking for with respects to outcomes. In parental authority, the parents are acting as surrogate decision makers for their child. They're working to determine what is in the best interest of their child, often with limited information about the child's preferences. And the idea of comparing autonomy in adults to parental authority in pediatric situations is really not comparable. And the big reason is that the parents, when trying to consider what's in the best interest of their child, is also considering other aspects to their world. They may have other children with whatever decisions they're making for their child might influence how that might look. They have to take a look at what the family needs as a whole, and they're not any decision they make for their child is not necessarily all based specifically on just what is in their best interest of their child. Also, the idea of we're going to talk more about quality of life. The parents are going to have various feelings around that, and that's going to very much influence the idea of decisions that are made as conversations between the healthcare team and the parents continue.
Why don't we call it parental autonomy then?
Because the implication of the autonomy would be that well, a couple of things. The parents are not making decisions for themselves. They're using surrogate decision making with respects to their child. So there's a difference in respects to that. And again, even in surrogate decision making, the implication of that phrase would be that you're only considering what the preferences of that patient would be, or trying to understand and take into consideration what they know about their child. But with respects to parental authority, or when parents are making decisions for their child, it's not just about specifically the child. There's other aspects that are being considered.
I'm having trouble with the clicking. So one of the questions we get asked a lot is, and we assume, well, maybe it's fair to assume that some of you have this question, but the question is, what do parents have authority over? And it's a good question, it's an important question, and it's a question that generates a lot of discussion. We are going to propose, and I mean, this is not just Drew and my thinking, but that parents have authority over defining the best interests of their child. So if you see on the circle graphic on the left-hand side, when we're talking about what does that mean, we're talking about parents representing the preferences of the family and the child, even the adolescent. We're saying that they have authority over the definition of quality of life, which is an important distinction because oftentimes we run into teams who believe they get to define the quality of life of parents or of children. And in fact, it's the parents who carry that authority to define the quality of life. It's also the parents' responsibility to bring forth relevant cultural factors and beliefs. And all of that kind of goes into a concept of best interests. So it's parents who see all of the picture. They see the big picture outside of the hospital, according to their culture, according to their family values. So they get to be the ones that define what's in the best interests of their child. Additionally, parents have decision-making over decisions that fall into what's called the zone of parental discretion. And this is not what Drew and I have come up with. This was the work of Lynn Gillum, and it's published back in 2016. We do have a reference list at the end of the presentation. But the zone of parental discretion is the kind of middle area between where treatment is obligatory and benefit greatly exceeds the burden. And that's where we treat, right? That's where there's significant benefit, there's maybe minimal concern for harm, the benefit is clear to all people involved, treatment's obligatory at that point. And on the other side, we have the space where treatment's not obligatory, where all treatment's going to do is harm and not provide any benefit, and we don't provide that treatment. And in between, there is a tremendously large space where there is either non-treatment would be optional or treatment would be optional. And ultimately, there's a trade-off between risks and harm in that conversation. And that is what we call the zone of parental discretion. So a lot of times what we're tasked for with some of these decisions is asking ourselves whether we think a decision falls into the zone of parental discretion. And if so, that's where parental authority comes into play and parents are able to exercise their authority over that decision. So I do want to speak real quickly. So in the session that we just came from, one of the questions that was posed about this case was about parents who share custody and which parents gets to make the decision. And you're going to hear us as we continue on and talk through. We're going to talk about parents collectively and as a joint unit. And I want to call out, because this case specifically had the contextual feature of parents who were separated, I just want to call out that the goal in these cases are to get everyone on the same page. So in this case, we'd be telling parents why we're working to get parents on the same page, rather than trying to spend our time deciding which parent we're going to let make the decision. They share custody, they split time. So really it's about coming to a cohesive place where everyone is on the same page together. Okay, so if we're going to talk about what parents have the authority over, it leads us into a question of what the clinical team has authority over. And we're going to argue that the clinical team, we're going to state that the clinical team has authority over defining medical beneficence. So medical beneficence is the determination of what's going to be medically beneficial for this child. That can include, it's the medical team's job, the clinical team's job, to understand the key medical facts, to know where there's certainty regarding risks and benefits. And sometimes we can't just take certainty at face value. We have to take extra steps to actually say, okay, if you're certain, what does that mean? You might say, well, I'm 60% certain. So that's not the same as being 99% certain. And we also need to put it in the context of knowing that we're rarely 99% certain about almost anything. But we have to figure out just how certain we are, how much uncertainty is there. And then the clinical team is also going to know about reasonable alternatives. What are some reasonable alternatives that exist to the current plan of care, to the current situation? And all of that kind of comes together into this sense of what is medically beneficial or medical beneficence. So that's what the clinical team's defining. We also want to take a moment and ensure that the medical beneficence is placed into the context of the goals of care. So if a child is terminally ill or has really complex needs and maybe is on hospice care, their goals of care are going to look really different than a healthy child that's presented to the hospital with a specific concern. And the medical beneficence picture should change and does change based on those goals of care. We wouldn't do the same thing for a child on hospice whose goal is to stay at home and be comfortable as we would for a child who has a condition that's fully reversible and we expect to be able to reverse that. So the context of the goals of care should be part of the lens that we look at when we're looking at what a medical beneficence is.
And Sarah, I mean,
Yeah.
one of the things you gave two different examples of goals of care when it came to a child who, for example, is on hospice with a certain cancer, right, where parents had chosen that direction. Based upon the goals of care, the same diagnosis in that same patient, parents, again, if there's a lot of uncertainty around the prognosis, could have decided to, instead of going to hospice, give chemo and to go into a whole nother direction based upon what they wanted to do. Again, as long as there was some level of uncertainty about that prognosis, that could make both of those decisions okay.
Absolutely. Yeah. And it should say that as we say that parents have responsibility for, have the authority over best interest, that includes some of the goals of care, unless we're falling, I'm going to go back a slide real quick, unless we're falling into this treatment obligatory space where we generally know we're there. We generally know that if parents don't choose to engage in a treatment that has really a well-established benefit, even if it comes with some harm, because we know that we do a lot of harm in the context of the pursuit of benefit. We're in this treatment obligatory right-hand side, then they may not get to determine the goals of care in the same way. And I think I just managed to jump. What's happening? I'm moving us forward slides, not back slides. Sorry. There we
That's
go.
okay. Well, you can go now. You can go up one more.
All right, there we go. So
We're
what
good.
about uncertainty, Drew?
Well, as we were just talking about, the idea of as you take a look at um, the y-axis and the medical beneficence and the x-axis and parental authority, we were just talking about the idea of certainty, right? If you're certain, uh, trying to do a intervention is not going to be helpful. And not only is treatment not beneficial, but if it's not going to help, you can basically, based on that medical beneficence, even if the parents want to do an intervention, they may not be allowed to, or they may not get to, with respect to the certainty around that. And the same on the other side. If a parent doesn't want to do something, but there's certainty that doing that intervention is going to absolutely help, and I think you could look at Jehovah's Witness and transfusions as an example of uh, the idea of treatment obligatory. That one has supported again legally with respects to overriding the cultural beliefs of a family and what they feel is in their child's best interest. So there are those circumstances, and falling within that idea is as uncertainty increases, the beneficence of the medical intervention is less certain, is less known. And if it's less known, even though you may feel that one thing is better than the other, one intervention is better than the other, if there's enough uncertainty with respect to the two of them, or if they're close to each other, then we allow the parents to make that decision. And that idea of uncertainty, though the medical team may have one preference on what they feel is medically best, for the parents and their decisions overall on knowing that what's in the best interest of their child, they may choose to do something else. And that has been discussed in other ways. This falls into that zone of parental discretion, but uh, Lainey Ross is somebody who likes to use the phrase, is it good enough? Right? Is what the family wants to do good enough for the care of the patient? And are we going to allow the parents, with respects to understanding the child's best interest better than the clinical team, make that choice?
And that's a good point. You know, we are using the language of best interest in terms of parental authority and parents getting to define that. And certainly, there are plenty of scholars who have argued that the term best interest isn't even the right term. And we know how complicated it's gotten when we've done consults, right? And the medical team says to us, oh, this is in this child's best interest. And they're crystal clear. And then we have the parents who are all in, right? Fully engaged, really engaged in care and part of the decision making, say absolutely not, the opposite of that is in their best interest. And ultimately, there's not much ability to navigate that, right? You're just at this kind of stalemate of everyone saying, this is what's in the best interest. And so that's where the zone of parental discretion becomes really helpful, because we can walk away from the debate over what's in the best interest, because you're not always going to get one side to acquiesce to the other, but we can actually ask the question of, are we in the zone of parental discretion? I don't know why I'm clicking so hard. There we go. Okay. So back to the case of Rose. This will be the third time you've heard it, but as a reminder, Rose has unfortunately fallen out of a slow-moving farm tractor, has all the clinical signs at the bedside of death by neurologic criteria. We're about 72 hours in. The team's given the window to make sure that there's no signs of recovery, and the team now wants to progress to testing for death by neurologic criteria. The father, who is a kind of equal parent in this, shares custody, splits time, has said that he's fine with it. His experience of this situation is that his daughter's gone. and he is not in a place where he needs to delay testing or anything else. He's ready to move forward. And on the other hand, we have mom, who is not in the same place as dad, has not gotten to the space of seeing or believing her daughter is gone, and is very much not wanting to test. Mom's aware that the result of the testing might be the declaration that Rose is dead and dead by neurologic criteria. And mom has said that she does not have any interest in that testing with that potential outcome. Okay, so these are some case questions to get us thinking.
Okay, so should Rose's mother be allowed to refuse brain death testing?
And this is the question that came, right, in a case like this, and this is not an exact case, it's a de-identified kind of amalgam case. But we've had this question, should we allow the refusal of brain death testing? Which then asks the question, right, is this something she's allowed to have parental authority over? It's not an easy answer.
Do you want to?
We're gonna present it like it's easy, right, Drew? That's what we're gonna do today. No
Of
problem.
course, everything's easy.
We got this.
Everything's easy. So, so determining if parental authority is present, right, in brain death testing, meaning do they get to have a say? So what we know is that one doesn't have to have consent, right? The conditions of registration cover the testing. So we know that you don't have to have it, but does that mean you shouldn't get it? So should parental consent be needed for brain death testing? And we really feel the answer is not necessarily. And why isn't it necessary? Well, I think that the there's a barrier, obviously, with the idea of parents having to give their consent to have the testing done because there is disincentives, right? Because as with this case we were talking about, if the brain testing is done and it shows that there's death by neurologic criteria, then one has to cope with the fact that their child is dead. One has to go be present with the idea that their child will no longer be present with whatever is removed in terms of support. And it is problematic in many times for that reason.
Just thinking about the emotional burden, right? Like parents do not want to be or feel complicit in the death of their children. And if we shift to a consent model where we're asking parents to consent to the testing, it's really problematic, A, because we don't actually need their consent because it's covered by the conditions of registration, but also we're just adding burden to parents in a really emotionally and psychologically burdensome time anyways. And it really feels, I mean, certainly from my perspective as a social worker, I was like, do not seek consent if we don't need it. And the result of the consent is that some parents may feel complicit in their child's death.
And
I'm sorry, but you have one parent that's willing to say yes and the other one who's willing to say no. And I guess the question is does that add burden to the other parent? So since you have two different answers from parents, you know, one doesn't feel like it's a burden. They're already willing to say yes. And the other one is saying no because they're not ready yet to accept that answer.
Yeah.
So it feels like to me, because this is a kind of a split decision, so to speak, from the parents, you know, this family has to live with whatever that decision is, and if the medical team overrides the mother's desire, the father bears the burden now of having said yes.
And I think we're going to say that we don't need consent for testing, right? That we're not going to ask parents whether it's okay for us to move forward with consent. We're not going to say, can we move forward with brain death tests? We don't need it, right? It's part of the condition of registration. But what you're bringing up, Carla, is when you have two parents that aren't on the same page, it does mean that as we take the time to negotiate through this situation, because dad's ready, he will be experiencing the emotional and psychological experience of having his child continue on as we navigate this experience, right? So, and that's and so there is a kind of differential, like we do have two parents with different needs and different emotional experiences based on the work that we're doing. But I think you've also highlighted why we don't want to ask permission for testing. Because if our goal is to get permission for testing and we have one parent who's willing to do it, we could just go over there and get permission from testing, and then building a ton of conflict for them into that scenario. So instead of getting consent for the testing, right, we're going to actually say we don't need consent for the testing. We're not going to ask for it, but we are going to allow for dissent of the testing.
I guess the other thing I kind of get stuck on is that it's been only 3 days. That doesn't really feel like a long time, and especially time for a family to accept that their child is dead. Did something happen between the time the child came in and until the medical team's trying to make this decision? Like, was there, a chaplain that came in to talk to the mom? Was there, any counseling or conversation or any preparation? Or it feels very quick to go to this, I guess, is just from my perspective.
Yeah, we can. We'll give you a better flavor for this. Things were conflated in terms of timelines in general. These questions did come up on day 3, but a lot happened with respects to that. So we'll give you some information about that towards the end.
And I'll just add too that standard practice would be that from the moment this child came in, that the ICU doctors are talking about the nature of the injury and are beginning to prognosticate. So they've had 3 days of very concerning of communication of the degree of concern regarding the survivability of this injury.
Well, we've talked about the idea of informed consent versus allowing dissent. I think part of the conversation about the need for consent and having two parents if one of the parents gives consent, then if consent is needed, one could proceed if that's what the goal was, but that wasn't the goal in this situation. Go ahead. And why would we allow for dissented testing? Obviously, lots of conflict to avoid. And you have to think about the outcome of if you proceed with testing and you have satisfied criteria for death by neurologic criteria, then you're declaring the child dead. And then what? What if the parents aren't going to allow removal of the ventilator? What happens with respects to insurance? If you haven't figured out what you're going to do in that moment and that hasn't already been discussed, meaning make sure you know what you're going to do with the results of the information and what's going to happen with that before you get that information. Because if you don't, a lot of things can happen that are consequential and not meant to have happen. And then lastly, is the testing, what if it doesn't align with the parent's interpretation of what is in their child's best interest or child? If the family really has a strong belief and is waiting for a miracle, are they going to accept the idea of death by neurologic criteria? And certainly there's lots of examples of patients and situations in which that happens, right? So that's something also to consider.
And we don't always talk about the benefits of conflict avoidance in these situations, but I think, as they talked in the last session about moral distress and fatigue and compassion fatigue, conflict between the team and parents adds significantly to that. If you do the testing alone, or ignore mom's dissent of the testing and just plow forward, and you do get results that this child meets the criteria for death by neurologic criteria and are going to declare this child dead, the parents can go to courts. They can ask you, they can put barriers in place, legal barriers. They can slow the process down. And then you have ongoing and very significant conflict between teams and parents who are all trying to care for a child and who ultimately have the same goal of doing what's right for the child. They just have different interpretations of that goal. And both Drew and I will argue that avoidance of that conflict is important, and it actually should be a goal of what we're doing in pediatric ethics, even though we often don't talk about it. We like to debate what we're allowed to do and what parents are allowed to do and all of this, but conflict avoidance is important, not only because it's much harder to move a family, right, once the conflict has set in and each side has declared their positions and they're at a standoff. It's much harder to move a family in that, and the fatigue and the moral distress and the burnout that can cause for the team is significant. And for these reasons, we think it's actually a really good reason to allow for dissent of testing to try and avoid that conflict.
Right. And in the chat, when someone's talked about moving towards shared decision making, if there's conflict, how do you have shared decision making?
Right.
Again, we've all knows those situations. And so to anticipate what one needs to do to try to navigate the idea of having things being shared, you have to have trust, and conflict really interferes with that.
Okay, so let's apply the zone of parental discretion to the cases. We've talked about it. So on one side, on the benefit side, we have the option for organ procurement, and organ procurement and death by neurologic criteria are intimately connected. Organ procurement is one of the reasons we have definitions around death that include death by neurologic criteria and not just cardiopulmonary cessation. So you have the option for organ procurement, which we know is a meaningful experience to many families. And we also know it's a meaningful experience for medical teams, right? We know that we have lots of ways in which we see this as the transition of tragedy into hope. And so that's a very real benefit. And it doesn't mean the family will consent, but it means we have the option for organ procurement. And it also means that the team doesn't have to continue care. And you might say, well, Sarah, Drew, why are you saying that's a benefit? Well, a medical team does not want to continue providing care to someone that's been declared dead. That feels wrong. It feels abusive to staff. And that's what we hear. We'll say that staff will say to us, like, I think this child's dead and this feels abusive. This feels like we're not letting the family grieve. We're like continuing to do this to a body, and it feels terrible. So the benefit is that, right, if we test, we get results, we have the option for organ procurement, and the team doesn't have to continue care. On the harm perspective, right, we talked about that we may feel like we're going to remove a ventilator forcibly over parental objection. We have the conflict between team and parents, and something else that has come up when we've done these consultations is that we may have failed. We often have failed to engage in a palliative care approach. And that's because the care has been determined to be, right, the child comes in, we have immediate concerns about the survivability of the injury. We start talking with parents about that. We go through X number of days, 3, 4 of those days initially. We get to that point where we're confident that this child is dead by neurologic criteria. And the kind of medical pathway that we're on is that you wait for those clinical signs, you get your brain death testing, you declare the child brain dead, then you talk to the family about organ procurement, and you kind of make a plan for what the kind of final removal of support looks like, depending on if they're going organ procurement or not. That is a pathway that often lays itself out. It's like the highway of death by neurologic criteria. You get on the highway, you're going for it. on the other, like we have a highway on the other side over here that we're also very familiar with, right? And we use that highway in a palliative care approach all the time when we don't have the same clinical findings of death by neurological criteria. So while we're very familiar with the palliative care approach and how do we talk to parents about what this injury means, what it looks like, what this child's future quality of life is going to be, prognosticate the best we can about these things, we're not used to doing that when we believe or when we have reason to believe that death by neurologic criteria is happening. And it really is like a highway. It's like your freeway, you got guardrails on both sides, and it's hard to get off and it's hard to move. You're just kind of on this track. So we've talked a lot about uncertainty, and so the application of this conversation to death by neurological to testing for death by neurologic criteria is an interesting application. And Drew and I talked a lot about this when we were building this talk, because there's lots of situations where the zone of parental discretion is a little bit more clear, I guess. And the application of this to testing for brain death is interesting because, as we started, we already said that we don't need consent. So we don't need consent, right? Which kind of says to ourselves that testing is really up to the medical team. But since we've already argued that there's benefit in allowing for dissent testing, and we're saying, yes, there's benefit, but there's also harm at play, we're here making the argument that that testing for death by neurologic criteria falls into the zone of parental discretion. And it's an interesting overlay. I feel like we could have made this talk easier for ourselves, but we didn't, because we were having some fun exploring this topic. So what we would say now is that it's time to slow down. And in the case that we had that was similar to this is exactly what we did. We said time to slow down. And you know, before, I think, Carla, when you had mentioned it, you were bringing up like the concept of time-limited trials, which we love in ethics. Like, let's just give this a little bit of time. Let's do a little bit of work and see what we get to. I want to acknowledge that slowing down is impactful to these parents in different ways, right? Slowing down from the mother's perspective is perfect. Maybe we're going to take the brain death testing conversation off the table because we're in conflict. And so that's aligned with what she is needing and wanting. For dad, it's not necessarily aligned. It may be really painful for him to have us slow down. But we'll go back to the fact that our goal is to avoid conflict, but also to have everyone on the same page. And that may mean that we're making one parent less happy, or we're aligning the care less with that parent's goals. But the reality is that if they share custody and they split time, we have no real other option. And so we are arguing that this decision does fall into the zone of parental discretion, and that our recommendation is, in these situations, not only do we slow down, but we shift energy and effort to the palliative care approach. We get off the superhighway of testing for brain death, and we say, let it go. Let's jump over to the other highway, and let's follow a more windy route through the mountains. If I'm going to lean into this analogy, and let's slow down, take a palliative care approach, and go back to basics and make sure that we understand mom's goals for her child, how she values quality of life, what that looks like, and then help her understand what is going on with the child, how the care often does not align with goals around quality of life, and slow the whole situation down so that she's got the time she needs, and we're avoiding that conflict. And the other benefit to this is, you know, I'd started by saying, oh, the team doesn't have to provide care to someone who's dead, which is very distressing to them. The other benefit of slowing down and switching this is that we haven't reframed, or we have reframed this as from care of a dead child to a palliative approach where we know we have a child with devastating injuries, and we're going to support parents in giving them the time and the space to kind of move to a shared decision-making model. But also, even if nothing has changed about our clinical assessment of this child, just getting off the superhighway that's focused only on testing allows us to help parents really come around and understand that this child will never breathe on their own, that they're likely to have challenges sustaining their organs. And what we didn't do in this talk is we didn't get into the real kind of ethical debates around death by neurologic criteria. And not everyone agrees in pediatric ethics that it is truly death. And it's not the kind of clear-cut determination of death that sometimes we like to think it is, which again supports this concept that testing and that it's reasonable to allow for dissent of testing, to put this into the zone of parental discretion, and to shift our energy and our effort into a palliative care approach. So I want to take a moment and talk about bias in pediatric ethics because it comes up a lot in cases like this. And often what we'll see, and I would say that much of our talk, while we didn't specifically call out bias all along the way, much of our talk is informed by the ways in which bias impact the thinking that go into these cases. So for example, ableism, right? This child won't have a quality of life worth living. Now, if we think a child is dead by neurologic criteria, then we may be more certain that we think that's a life that's not worth living. But we have lots of examples where clinical teams are making statements or determinations that a quality of life isn't worth living, and there's a lot of ableism informing that decision. So this is where our disability ethics and our needing to expand our thinking and grow our thinking about disability is really important. We hear a lot about classism, right? Oh, they won't be able to care for this child. They don't have the money, they don't have the resources. And there's an implication that the fact that they have lower resource levels mean that they won't be able to care for a child is very classist, right? And I say that as a social worker who understands the challenges of our community resources and how we've built our structures to benefit some over others. And I say all that, and I'm here to call out that kind of language in this space. We also have institutionalized and systemic racism, which we need to be really careful when we're thinking about parental authority, because we also will deem a parent of color's choice as more harmful or less value-based than we might of white parents. And this is really problematic because we will say that they're making decisions for other reasons other than the fact that these are their family values and that these values matter. And all of these things can inappropriately impact parental authority. They can change the way in which we think, in the situations in which we think parents should have authority. And we should be very aware of that and really thinking about that as we have these conversations and as we think through these. I included the bias pause that's here. I think it's out of Vanderbilt, but now I'm forgetting exactly the source. The source that I've cited here is a secondary source for it. But it's a nice way to remind everyone to pause. It's similar to what Dr. Dudzinski was doing in our morning talk when she had equity pauses in there. But there's a nice little acronym here if that's meaningful to you. And I really want to call it out because we can see, and we've seen this in our consults, we can see that we get consulted differently for similar situations based on some of the characteristics of the family and or the child's situation. And that's just something we want to be aware of and really careful. Okay, lastly, now this is a little bit about me. I'm currently in the certificate program for pediatric ethics out of Children's Mercy. And I wanted to just reference, this is where I got the kind of green circles from that you saw earlier. This is a tool that I'm working on developing that is a behavioral-based approach to pediatric ethics consultation that mirrors some of what we've talked about today. It builds in reflection points where we're able to ask ourselves to slow down, to reflect on how power and oppression are present in the consultation process and how they are showing up in our decision making. It encourages us to stop and think about a bias pause, but it also does that very explicit defining over what parents get to define and what the clinical team gets to define. So we included this just so you would see where our little green circles came from. So we have about 15 minutes left, which I think was our target, Drew, for questions and discussion. So we are, and I can't really, I like the chat shows up, but I can't really actually read what the chat says. I can't get like a few words of it. So I don't know how to see the chat.
Sarah, if you're done with presentation, you can get out of presentation mode and then you can see the chat much more easily.
Oh, okay. Did that do it? Oh, it did.
So I suggest we take some questions right now, and what I'll do is right at the end, I'll give a little bit of summary on the information about the outcome of this case, if that works for you, Sarah.
Yeah, I just want to respond to, I'm kind of going through the chat. I want to respond to Brenda's
yeah, of course.
About respect for Rose, right? Even if she were declared dead by neurologic criteria. And absolutely, right? Personhood should be respected all along the way. And I think that our nurses do a tremendous job with that. And I actually think it's what creates some of that conflict when they have to continue care at the bedside, when they believe that someone's dead, because they cannot engage in that really kind of loving care that they want to provide to Rose. And instead they have to engage in much more invasive care that feels really wrong to them. And it feels like an assault on her personhood. And so, yes, absolutely. Yeah, so questions for us.
You can either raise hands, put them into the chat. You know, when Sarah and I were talking about other cases, there are cases that are obviously more clear cut about being within or outside the zone of parental discretion. Probably the most common one is premature gestational newborns, right? So again, the idea of when to resuscitate or not resuscitate, and whether one has to, the family has a choice, or doesn't, or recommends not resuscitating. And that schematic that we had in terms of burdens to intervene or to not intervene, and then in between what we're talking about, that zone has to do with, again, gestational ages when newborns are born. So at 23, 24 weeks, that's in a zone of parental discretion based upon the outcomes or the potential morbidities associated with being born that prematurely, and families get to participate in shared decision making. At 21 weeks, they do not. The viability is so low that to do an intervention is not recommended, and even if families wanted to, nobody in the country would resuscitate at a 21-week gestation child. And the idea that this has changed a little bit, which used to be 23 was the low end, now 22 weeks is being added to that based upon survivability. But this is the most commonly thought about, with the idea of when do parents get to decide or not get to decide about these types of interventions on what the benefits or not, based upon the best interest from their perspective.
Yeah. So there's a question in the chat from Dr. Roots, is asking for a time frame to test a reasonable approach. And I think we would say it absolutely is. We do it a lot. And we don't necessarily say like, okay, we're going to test in a week, but we like to talk about time frames to diffuse some of that kind of tension, right? To diffuse the superhighway that we're on. And that's a way to be able to say, like, let's take 3 days and we'll reevaluate. So while we may not say we will test in 3 days, because in 3 days we may be in this situation, we've often said, okay, we're going to take 3 days to just stop talking about it. Let's diffuse everything. Let's give parents more time to be with their child. A lot of times parents are like, well, what if they wake up tomorrow, right? What if they start moving around? So all the time that we give to parents increases the amount of knowledge and embodied knowledge that they can feel and understand about their child. So absolutely timeframes are reasonable. And I do think, I mean, I'll just say that I think there are different cultural approaches across the country to this question. I think there are parts of the country where they are more willing to act on the results, even if it's not what the family wants. And there are other countries where that is true, like in the UK, they have courts that will weigh in on these sorts of situations, so they might be much more likely to test in spite of the family. Here in Oregon, just culturally, we're less likely to do that. It's not really our style. And so it might depend on where you're at, but a time limited trial or a time frame to kind of diffuse and let people breathe and let there be a little bit of, I call it room to breathe, just because a lot of times when we get involved in these cases, we're just like, okay, we all need to breathe. Everyone needs a little space.
I mean, what we know is, particularly in acute situations, that the clinical team is much more attuned to a prognosis and getting used to the idea of a poor prognosis, right? So they are always ahead of the family, always.
Mm-hmm.
So and particularly when things are, when patients have been there for a while and things are not moving in the way that the clinical team wants, but they're not necessarily prognosticating on that, but they're getting mentally prepared for a poor outcome even before they're talking to the family about that. And when they do talk to the family about it, how long does it then take the family to start letting that sit in and having them get used to that? So timelines is always an issue with respects to a poor prognosis when the clinical team feels they understand that and there's some certainty around that, and then sharing that with the family and having that sink in. And there's always a delay with an ethics consult. Lots of times, stating to the clinical team, I think the family just needs some time to get used to this before you start pushing an agenda with respects to definitiveness is very helpful.
Yeah.
It would be interesting to look at a study about what the process of grief looks like, depending on kind of what you were talking about, like the courts in the UK, or a culture that allows time to process versus a culture that says, okay, we're going to do the test and then we're just going to move forward. Because I do think that would impact the family's grieving process and how they viewed that death.
Yeah. And there's palliative care literature that talks about what physicians know on average 90 days sooner than what patients know, and it's more adult focused. But sometimes I think what we can interpret that research to mean to almost give weight to what we on the clinical team know 90 days before someone else does. And I don't know that we could say that it's exactly that amount of time in these acute situations, because even in this case, we had a father who in 3 days had gotten there already, and really perceived and understood the situation to mean his daughter was gone. But I do think we can take that research that says we know it 90 days before, and it can manifest in a sense of like, well, we know this is going to be the ending, right? And when that ending is death, it can be hard to continue interventions and support. And the reality is that it's not a lack of information that has patients knowing that 90 days after the providers. It's also the emotional experience, right? And the psychological experience. And this is, no one has children expecting them to die before their parents. And so, I mean, we're lucky. I think Drew and I are both lucky that we have teams that kind of are very aware of this and are very used to giving families time. And the question of testing about neurologic criteria is a tough one because it's a test we don't need consent for. And sometimes I think that alone kind of gets in our head and shifts things. We have about 5 more minutes if anyone has any other questions.
I took care of some kiddos who had conditions that were going to shorten their life, and there really became a point in time in my practice in which my focus was no longer about management and treatment, but it was getting families ready for death. And
Yep.
I think that, you know, it's a tough role as a clinician to do that, but that's such an important role to help families move towards that. And it just takes space and trust and kindness.
Yeah, which is fundamentally the approach we're advocating for in these situations when there's resistance or dissent to testing. Yeah, because you're right, exactly. Space, kindness, kind of a refocus on the goals, and giving people a different kind of communication, right? The communication that we give when we're educating families about the lead up to brain death testing it's very important, right? And we know that the many families, I haven't seen a study on it, but I'm guessing the majority of families don't fight that, right? Because just as this dad had said, I understand she's gone, lots of families has had that experience. And I've worked with many families who feel like we've gone past the point of where we should have gone, and they can see that in hindsight, but they couldn't have in that moment said, oh, we should have stopped there, because that's really hard to do. Yeah, sorry, I don't know where I was going to end there, but yes to all that. That is the approach, right? That's what we need to be doing. That's that palliative care approach that we want people to think about when you run up against a family who's dissenting to something, even if it's not something we need consent for. That allowing for dissent is, we should talk about it just as much as we should talk about informed consent. And I'll also say, because I feel really strongly about all the things we force people to consent for, especially when it can be really impactful to their child's life, is that there's lots of situations in which we should allow for dissent, right? Instead of asking for permission to withdraw the ventilator, you know, being able to say like, okay, we're going to withdraw the ventilator, and then pausing and allowing and creating that space where dissent can come in, rather than asking for constant permission from families when the result of said permission is the death of their child. Not, and we know they haven't caused the death of their child, but emotionally we can see the connection between them. Well, I said okay to that, and then my child died. So I want us to be really mindful around those places where we ask for consent, and consider a model where we allow for dissent instead.
So real quickly, we can let you guys know that the flow studies were not done in this patient. The patient continued to be supported for about a total of a month after they presented. Ended up having some other physiologic deterioration that allowed the parents to let go and remove support. And this mom was really, really thankful. She really appreciated the care. And we got involved about 2 weeks in from the admission of that patient when ethics got involved. Some of the framing of the idea of causing pain and suffering to a child, which again really doesn't play out if you believe that they're brain dead with respects to what they're experiencing, and the question of care with respects to who is the care of this child, who's going to take the burden of this death, and what are we doing to help alleviate some of that burden. And so that's how that was the conclusion of this case.
And we wish we had gotten involved sooner.
Always.
There was a lot of conflict and struggle and strife. I mean, our teams are excellent and they do a great job at working to minimize that conflict. But yeah, it's true, always on getting involved earlier. We appreciate you all being here. We know this is a tough case. We have a break till 3:30, and we just want to thank you all for the conversation and for sharing the space with us tonight.
Yeah.
Today.
Thanks, you guys.
Thanks.